Hi guys, if I'm audible and visible, please send your thumbs up in the chat box. Audible and visible? If I'm audible and visible, please send your thumbs up in the chat box. Okay? Okay, Ashfaq, Pooja, Dr. Aesthetic, Satwik. Okay guys, so let's start. Let's start. You can see the first question. See the first question. A 12 years old man, presents with fever and right upper abdominal pain. You can see fever and there is right upper abdominal pain, right? The examination demonstrated in the attached video elicit inspiratory arrest due to pain. So can you see here? There is inspiratory arrest due to pain. The clinical finding is most suggestive of which of the following condition. So guys, see this and tell me what's the problem here. You can notice that the surgeon is pressing, can you see the tip of right ninth costal cartilage? Okay, you can see the right upper quadrant. So pressing tip of right ninth costal cartilage, and here patient is catching the breath in inspiration. So there is inspiratory arrest due to pain. And you know here, what is the name of this sign? All of you know that this is Murphy's sign and this is seen in acute cholecystitis. So what is the name of this sign? This is known as Murphy's sign. Name, this is known as Murphy's sign, right? What is the other name of Murphy's sign? Anybody? Yes, anybody who can tell me the other name of Murphy's sign? All of you know this is also known as Nonin sign. So Murphy's sign also known as Nonin sign, right? This is the sign, I'm repeating it again. On pressing tip of right ninth costal cartilage, patient catches the breath in inspiration. This is one question. Second question आपको पता है कौन सा आता है? They ask you that there is hyperesthesia at inferior angle of right scapula, and if there is hyperesthesia at inferior angle of right scapula, that is known as Boas sign. So what's the name? Boas sign. That's known as Boas sign. Boas sign. So that is hyperesthesia at inferior angle of right scapula. Clear? You can see hyperesthesia at inferior angle of right scapula. Clear? So hyperesthesia at inferior angle of right scapula, right? Okay, clear? That is Boas sign. दूसरा question जो हम लोग expect करें, I'm telling you, there is another question which we are expecting. It was asked long back in INI-CET. It was a video based question, and what surgeon was pressing? Surgeon was pressing a point. It is located between spino-umbilical line at the junction of medial 2/3 and lateral 1/3. So at the junction of medial 2/3 and lateral 1/3 there is a point, and surgeon is pressing the finger at that point. और question में क्या था? That this is the most tender point of acute appendicitis. Guys, tell me what is the most tender point of acute appendicitis? Tell me. Yes, that's known as McBurney's point. So that's known as McBurney's. So in acute appendicitis we can get another question, McBurney's point. It's मैकबर्नीज पॉइंट. और मैं अपेंडिसाइटिस से रिलेटेड क्वेश्चन प्रिडिक्ट कर देता हूं आप लोगों के लिए. मोस्ट प्रॉब्ली वी आर एक्सपेक्टिंग वन क्वेश्चन रिलेटेड टू ऑशनर शेरन रेजिम, अपेंडिकुलर लंप, अल्वा रैडो स्कोर और मैंटल स्कोर, और ज्यादा चांस है दे आर गोइंग टू आस्क यू द इंसिजन्स ऑफ अपेंडेक्टोमी. This is one question. Second set of question which might be asked, that will be related to laparoscopic cholecystectomy. तो हो सकता है they are going to show you the video of laparoscopic cholecystectomy and they are going to ask the triangle. Which triangle? Callout triangle and hepatocystic triangle. So these are the questions expected related to this topic. Okay guys, so these were the questions. I'm repeating which questions we are expecting. One, surgery related to lap chole, Callout triangle, hepatocystic triangle boundary. This is one question. Second, they might ask you Strasbourg classification and Bismuth classification. So these are expected questions in relation to gallbladder and bile duct. Okay. Next, you can see the next one. Very easy. See this picture. In this video, you can see this is a 24 years old man presents with acute abdominal pain and patient is having fever. Examination demonstrated in the attached video elicit severe pain on sudden release of pressure. So whenever there is severe pain, you can see this severe pain on sudden release of pressure. This is known as rebound tenderness. Guys, what's the name? It's rebound tenderness. So the name, this is known as rebound tenderness. And guys, you know, rebound tenderness, it is suggestive of peritoneal inflammation. ये appendicitis में भी हो सकता है. It can be seen in appendicitis, but obviously it will be seen on the right side in right iliac fossa if patient is having acute appendicitis. Here it will occur in peritonitis if the patient is having peritoneal inflammation. So it's not gastritis, it's not obstruction. In obstruction there is pain, but this kind of rebound tenderness is not there. It's not the renal colic. It is because of peritoneal irritation. So it is because of peritonitis. Almost everybody is correct. Yes, it is because of peritonitis. It's because of peritonitis. It's because of peritonitis. Clear? Second question मैं जो बोल रहा हूँ आपको, we are expecting they might give you chest X-ray with free gas under right dome of diaphragm. So pneumoperitoneum, chest X-ray with free gas under right dome of diaphragm. They will ask the management first resuscitate the patient by IV fluids, and after that perform exploratory laparotomy. Easy. Now see the next one. Next, see this picture. In this picture, can you see there is surgical scar? Can you see this? This is surgical scar. After that, what happens? Patient is having increased intra-abdominal pressure, and because of this increased intra-abdominal pressure, patient is having hernia, right? So guys, tell me what's the underlying condition? So you can see here in adult patient, which of the following condition is an important underlying cause of conditions demonstrated in the video below? So obviously it's not hyperthyroidism, it's not peptic ulcer disease, renal calculi, क्योंकि इनका लेना देना नहीं है in relation to intra-abdominal pressure. What will happen in portal hypertension? You know, portal hypertension increases the risk of ascites. In portal hypertension, there is ascites. These patients are also having hypoalbuminemia because majority of patients are having chronic liver disease. It impairs, what happens? There is impaired wound healing. So because of all these cases, you know, portal hypertension, chronic liver disease, cirrhosis, all these are the risk factors for incisional hernia. So all these are the risk factors for incisional hernia. Incisional hernia. Clear? So all these are risk factors for incisional hernia. Incisional hernia. Easy? So here what's the correct answer? Correct answer is option A. Okay. Now see the next one. Very easy. Guys, see the video first. Can you see the video? Just a moment. You can see this video. So here. See the video? Okay. In this video you can see this is pancreas. After that you can see the endoscopy is coming. We are injecting dye from below, and after that we are going to take X-ray. This is ERCP. Can you see with the help of this balloon or basket, I'm going to take out the stone, and whenever patient is having any kind of stricture, we can put the stent, right? So I'm repeating it again. You can see here, this is the picture, this is the picture, this is the patient. You can see here, this is the patient. What happens? First, I'm coming into the duodenum. After coming into duodenum, what happens? I'm going to inject the dye. And after injecting the dye, I'm going to take X-ray. Whenever some stone is there in the distal part, I'm going to take out the stone. So if stone is there in the distal part, I'm going to take out the stone. If there is stricture, I'm going to perform the stenting. So one question for all of you. आप लोगों के लिए question है, बताइए. ERCP is mainly done for the pathologies located in distal part of bile duct. Tell me. It is for the pathologies located in distal part of bile duct, or it's for the pathologies located in proximal part of the bile duct. It's distal part of bile duct or proximal part of bile duct? Guys, everybody tell me. It is for the pathologies located in distal part of bile duct or proximal part of bile duct? Divyansh, Vibhuti, very good. Roshik, almost everybody is correct. Distal part of bile duct. Remember, whenever some pathology is there in the proximal part of bile duct, I will go from here. And if I am going from here, what's the name? This is known as PTC. What is PTC? Guys, you know that it is percutaneous transhepatic cholangiography. So that's PTC. It is percutaneous transhepatic cholangiography. मैं repeat करता हूँ. Whenever patient is having stone. What kind of stone? Intrahepatic stone. Patient is having stricture. And these problems are located in proximal part of bile duct. So how to remember? For proximal we are going for PTC, and if it is located in distal part of bile duct, and for distal part obviously we are going for ERCP. Now one question, you know, what is the largest stone which can be removed by ERCP? Remember, By ERCP, we are going to remove 1.5 centimeter. There is another question, ESWL. What is ERCP? Endoscopic retrograde cholangiopancreatography. So maximum size of stone removed 1.5 centimeter. Whenever patient is having kidney stone, we are going to remove it by ESWL, extracorporeal shock wave lithotripsy, and with the help of ESWL, we are going to remove the stone size 2 centimeter. 2 centimeter. दूसरा question, imagine guys, patient is having size of stone more than 1.5 centimeter. In that case, give the incision. So in that case, we give the incision over CBD, and after giving the incision over bile duct, we remove the stone. Clear? So you can see the question. 40 years old woman, symptomatic choledocholithiasis, undergoes the procedure given below, ERCP. Demonstrated in the attached video following endoscopic sphincterotomy. What is the maximum size of CBD stone that can be removed using standard balloon or basket extraction without the need of lithotripsy? That is 1.5. So question for all of you. Guys, can you tell me what is the most common complication of ERCP? I am waiting for your reply, guys. Tell me. Yes, Haripriya, Veer, Sweda. Yes, Mind, Soul, Dhananjay Verma. Tell me, what is the, tell me. Yes, most common complication. Very good. Very good, Divyansh. Very good. Very good. So guys, it is acute pancreatitis. You know, after ERCP, patient is having acute pancreatitis. Let me tell you the symptom. There might be this kind of clinical scenario that in this patient, ERCP was done, and after ERCP, patient was having abdominal distension, patient is having nausea, vomiting. There is abdominal distension, there is nausea, vomiting. What's the cause? So patient developed acute pancreatitis, and in what percentage patient is having acute pancreatitis? Tell me. In 5%. So in 5% patients, patient is going to develop acute pancreatitis after ERCP. That's the most common complication. And you know, for CBD stone, what is the investigation of choice for diagnosis? MRCP. What is the gold standard investigation? That is ERCP. Easy. So this is 1.5 centimeter. Next. Guys, see this picture. What I'm doing under ultrasound guidance, can you see? I'm going to catheterize. Can you see? I'm going to insert a catheter. Where? Into the femoral artery. Via femoral artery, I am going into aorta. You can see. I am going into aorta. Okay. So you are in the femoral vessel, means femoral artery. Then you enter into aorta. Can you see? And after that, you can see there is a tumor in liver. And what I am going to inject? I am going to inject the chemotherapy agent. Can you see the chemotherapy agent? Simultaneously, I am going to inject the embolizing agent. So it is what? It is actually TACE. Guys, anybody can tell me what is this? TACE. Guys, can you tell me the full form of TACE? This is transarterial chemoembolization. So this is TACE, that is transarterial chemoembolization. And here, which drugs are used? How to remember? Mnemonic is LCD. The drugs used LCD. So in liver, we give cisplatin and doxorubicin. So guys, we are giving cisplatin and doxorubicin. Okay. Now let me see who is the genius over here. This is transarterial chemoembolization. Yes. So let me see who is the genius over here. Dr. Aesthetic, very good. Dr. Aesthetic. Swaida, very good. Very good. So guys, see, read the question. 63 years old man with cirrhosis, diagnosed with 4.5 centimeter HCC, confined to liver. Clear? The effectiveness of the procedure demonstrated in attached video is primarily based on which of the physiological principle? So whenever you are giving chemotherapy agent, you are giving embolizing agent directly into artery, it means the tumor is exclusively supplied by branches of hepatic artery. All of you know this basic thing, that hepatocellular carcinoma, HCC, it is exclusively supplied by branches of hepatic artery. It is exclusively supplied by branches of hepatic artery. So HCC derives most of its blood supply from hepatic artery, exclusively supplied from the branches of hepatic artery. Normal liver parenchyma receives its entire blood supply from hepatic artery? No. Normal liver parenchyma receives blood flow from portal vein and hepatic artery. HCC is supplied predominantly by portal vein? No, it's hepatic artery. Embolization increases portal venous perfusion to the tumor? No, it is going to block the supply. So what's the correct answer here? The correct answer is option A. So the correct answer here, correct answer is option A. Clear? So that's the correct answer. Correct answer is option A. It's option A. Easy? Now see the next question. Next question. Very easy. What is the most common complication of this procedure? Impotence, incontinence, retrograde ejaculation, urethral stricture. See the procedure. Guys, see this. Patient is in the lithotomy position. Okay. This is the resectoscope which is coming in the urethra. Can you see? There is the resectoscope coming in the urethra. Okay. After that, whenever you are reaching bulbar urethra, what you do, you make the penis straight. After that, what you are doing, you are resecting the chips of tissues, prostatic tissue, and whenever there is bleeding, I am using, tell me, fluid for irrigation. And guys, this was the question in one of the latest exam. Which fluid we are using? We are using 1.5% glycine. If you are using monopolar cautery, use 1.5% glycine. And with bipolar cautery, we are using normal saline. So monopolar cautery, 1.5% glycine. Bipolar cautery, we are using normal saline. Most important distal landmark, all of you know, it's veru montanum. Why? Because it is located just proximal to sphincter. So don't go beyond veru montanum, otherwise there will be injury to sphincter. So incontinence is not common, but the proximal landmark is not there. And if proximal landmark is not there, what will happen? Sphincter is injured, internal urinary sphincter. And whenever ejaculation is there, internal urinary sphincter, this urinary sphincter, internal, it is closed. But what happens during ejaculation? Yes, tell me, the semen can enter into the bladder. And if semen can enter into the bladder, what will happen? Tell me, retrograde ejaculation. So all of you know that this is TURP, transurethral resection of prostate. Guys, I am telling you, TURP, that is transurethral resection of prostate. I am repeating the important questions. What is the solution used? 1.5% glycine with monopolar cautery. It's monopolar cautery. And we are using normal saline with bipolar cautery. So with bipolar cautery, we are using normal saline. Normal saline with bipolar cautery. Most important distal landmark, that is veru montanum. It's veru montanum. Okay, somebody is asking what's the cause of retrograde ejaculation. Don't worry, Ranjan, I will explain. So guys, most common complication is retrograde ejaculation, 75%, impotence 10%, incontinence less than 1%. I'm repeating. This is the bladder. Can you see this? This is the prostate. What's the big problem here? There is internal sphincter here. This is under control of L1. Okay? Whenever you are performing TURP, what is the big problem? There is no proximal landmark. So this sphincter is injured. You know what happens during ejaculation. Ejaculation is because of sympathetic system. So semen should come out. Semen, it should come out. Why? Because the sphincter is closed, and when sphincter is injured, the semen is going in the bladder also. And when semen is going in the bladder also, this is known as retrograde ejaculation. Guys, can you tell me what are the other conditions in which you can see retrograde ejaculation? If you are giving alpha blockers like prazosin, terazosin in BPH, alpha blocker. Second, whenever we are performing lumbar sympathectomy for Burgess disease, and you perform bilateral lumbar sympathectomy, and you have to spare at least L1 from one side, but you didn't spare L1 from one side, in that case also, what will happen? Retrograde ejaculation. So it's lumbar sympathectomy. It's lumbar sympathectomy. Lumbar sympathectomy. Clear? So alpha blockers, lumbar sympathectomy. Got it? So that's the retrograde ejaculation. Retrograde ejaculation 75%. 75%. Right? मैं बता रहा हूं आपको, we are expecting one question from TURP. They might ask you, what is the other question? That after TURP, there is a syndrome known as TUR syndrome. TUR syndrome, also known as water intoxication, also known as dilutional hyponatremia. Dilutional hyponatremia. So in which patients you are going to find this TUR syndrome, guys? Tell me. TUR syndrome, whenever size of prostate is more than 75 grams or duration of TURP is more than 90 minutes. Duration is more than 90 minutes. So patient is having dilutional hyponatremia. First take out the extra fluid, give IV furosemide, still patient is not improving. Then we give 3% saline, and that is hypertonic saline. 3% saline, hypertonic saline. Easy. So this is how we manage. Okay. Here what's the correct answer? Retrograde ejaculation. Okay. Now you can see the next one. What is most commonly injured organ in this procedure? Most commonly injured organ in this procedure. Now see the procedure. See this here. Foley's catheterization is being done. You can see. After that you can notice here what? That I am inserting this hollow needle. First I localize the stone. See. I am localizing the stone. After that this hollow needle is inserted. There is a guide wire, you can notice, blue colored guide wire. Via this guide wire, I am going to insert the dilators which are going to dilate the tract. Easy. And then you can see this is the nephroscope. You break the stone and after that you remove the stone with the help of this Dormier basket. So guys, this is PCNL, percutaneous nephrolithotomy. You can see this is DJ stent being inserted. So all of you know it is PCNL. So I am asking 2-3 basic questions. Tell me, what is the most common complication of PCNL? Kidney is relatively hypervascular organ. So since kidney is relatively hypervascular organ, the most common complication is bleeding. Bleeding. After that, see the relation with kidney. There is pleura, colon, spleen. So most commonly injured organ, how to remember? Mnemonic is PCS. The most common organ injured, that is PCS, and that's pleura followed by colon followed by spleen. It is pleura followed by colon followed by spleen. Okay. Next question. Usually for 85% of stones, kidney stones, we are going for ESWL. Yes, but for rest of the stones, we are going for PCNL. So whenever size of stone is more than 2 cm, there is distal obstruction. Hard stones are there. Yes. In all these cases, patient is having UTI. In all these cases, we are going for PCNL, percutaneous nephrolithotomy. So I am repeating it again. Guys, can you tell me most commonly injured organ? Guys, tell me the most commonly injured organ, it's pleura. How to remember? Mnemonic is PCS. So mnemonic, it is pleura followed by colon followed by spleen. It's pleura followed by colon followed by spleen. So pleura followed by colon followed by spleen. Clear? Okay. So what's the correct answer? Option A. And most common complication, that's bleeding. Bleeding. So this was PCNL. After that you can see this procedure. See this one. See this procedure. Here you can notice that small stones are going out via ureter. This large stone is stuck. This is the large stone which is stuck. Okay. After that you localize the stone and with the help of extracorporeal shock wave, you can see I am breaking the stone. With shock wave you break the stone, stone fragments are going out in the urine via ureter. So this is ESWL, extracorporeal shock wave lithotripsy, and all of you know that what is the maximum size of stone removed by ESWL, that is 2 cm. Next, what are the absolute contraindications? What are the absolute contraindications? You cannot give shock wave in pregnancy and bleeding disorder because there might be hematoma. So pregnancy and bleeding disorder. It's pregnancy and bleeding disorder. Otherwise, most of the stones you can remove up to 2 cm. There are certain stones which are very hard, not easily broken by ESWL, and how to remember? The mnemonic is BHC2. It is BHC2. Guys, can you tell me the full form? BHC2, it is bruchite, hydroxyapatite, cysteine, calcium oxalate monohydrate. So you can see bruchite, hydroxyapatite. So it is bruchite, hydroxyapatite, cysteine, calcium oxalate monohydrate. It's calcium oxalate monohydrate. Can anybody tell me which is the hardest stone? Guys, tell me what is the hardest kidney stone? Hardest. Very good. Already you guys told me it is cysteine. So the hardest stone is cysteine. right? So we are going to discuss the question again. See the question again. If you see the question again, maximum size of stone removed, that is 2 centimeter. So correct answer option C, the maximum size of stone removed, that is 2 centimeter. 2 centimeter. Okay, so it's 2 centimeter, right? So this was ESWL. Guys, we can predict some more questions. कौन कौन सा क्वेश्चन हम एक्सपेक्ट कर रहे हैं मैं आपको बता देता हूँ. वी आर एक्सपेक्टिंग ऑन द बेसिस ऑफ लास्ट 5 years. ब्रेस्ट चैप्टर से हम लोग क्या क्वेश्चन एक्सपेक्ट कर रहे हैं? आई एम टेलिंग यू, ब्रेस्ट चैप्टर से वी आर एक्सपेक्टिंग T4B, T4D. We are expecting T4B, T4D. T4B means there might be purdy orange. There might be purdy orange. There might be purdy orange. Okay. So purdy orange और क्या हो सकता है? Yes, inflammatory breast cancer. So in breast, T4B, T4D. This is one question. There might be one question related to cystosarcoma phyllodes or breast abscess. Thyroid chapter में आपको बता दूं, we are expecting one thyroid malignancy, most commonly papillary carcinoma, जिसमें क्या होगा? Orphan NEI nuclei या medullary carcinoma thyroid. Clear? Another important point जो 100% आने के chances हैं, complications of thyroidectomy. I'm telling you, complications of thyroidectomy. Easy? इसमें क्या question है? Same which is being asked for the last 2-3 years. क्या? A singer after thyroidectomy is not able to sing in the temple. कौन सी nerve injure हो गई? You know, the most commonly injured nerve. This is external branch of superior laryngeal. So it is external branch of superior laryngeal. Patient is not able to elevate the pitch. Recurrent laryngeal nerve की वजह से hoarseness होगा. Third जो question trending है, if there is surgery, especially related to parotid, and what happens? The patient might be having weakness of some muscles around the oral cavity. Yes, कौन सी branch injure हो गई facial की? Injury of submandibular branch. Remember, submandibular branch, submandibular branch. Okay, so there might be a video of mastectomy जिसमें वो कॉम्प्लिकेशन पूछ सकते हैं कि mastectomy में कौन कौन सी नर्व इंजर हो जाती हैं? लॉन्ग थोरेसिक, थोरेकोडोर्सल, इंटरकॉस्टोब्रेकियल नर्व. लिम्फेडिमा का इमेज बेस्ड क्वेश्चन आ सकता है, लिम्फेडिमा का, और लिम्फेडिमा कन्वर्टिंग इनटू एंजियोसार्कोमा, इसका क्वेश्चन आ सकता है. ठीक है. थायराइड में हमने डिस्कस किया. यस, थायरोग्लॉसल सिस्ट का इमेज बेस्ड क्वेश्चन आ सकता है, ये आ सकता है. इसके बाद लिवर में पायोजेनिक लिवर एब्सेस, अमीबिक लिवर एब्सेस, हाइड्रेटेड सिस्ट, आपको ये पता है. यस, सैटेलाइट नोड्यूल का आ सकता है क्वेश्चन. गॉल ब्लैडर में हमने डिस्कस किया लैब कोली, कैलर्स ट्रायंगल, हेपाटोसिस्टिक ट्रायंगल, स्ट्रैसबर्ग क्लासिफिकेशन, बिस्मथ क्लासिफिकेशन. दीज आर वेरी इंपॉर्टेंट. इसके अलावा मेडिसिन सर्जरी पैथोलॉजी में प्राइमरी बिलियरी सिरोसिस, प्राइमरी स्क्लेरोजिंग कोलेंजाइटिस, ये आप लोग देख लीजिएगा. प्राइमरी बिलियरी सिरोसिस, प्राइमरी स्क्लेरोजिंग कोलेंजाइटिस. इमेज बेस्ड क्वेश्चन कौन कौन सा एक्सपेक्टेड है? यस, हीडा स्कैन. वी आर एक्सपेक्टिंग हीडा स्कैन, ERCP, MRCP, PTC. So ERCP, MRCP, PTC. Okay. Pancreas में we can expect question related to acute pancreatitis, or in pancreas we can expect question related to especially gastrinoma and insulinoma. So gastrinoma and insulinoma. Yes, gastrinoma and insulinoma we can expect. Esophagus में typical coin वाला question आ सकता है. The X-ray in which coin is located in esophagus. Congenital diaphragmatic hernia का question we can expect. एक question जिसके आने के chances बहुत ज़्यादा हैं, that is motility disorder, and I'm telling you bird beak, rat tail, pencil tip appearance. So what? Achalasia and diffuse esophageal spasm, corkscrew. Achalasia and diffuse esophageal spasm. बोरहाफ सिंड्रोम, मैकुलर स्ट्राइड, ये आ सकता है क्वेश्चन. स्टमक में अल्सर आ सकता है. स्टमक में ड्यूरनल अल्सर का परफोरेशन आ सकता है, इन विच वी आर गोइंग फॉर ओमेंटल पैच रिपेयर, दैट इज क्लासिकल. पेरिटोनियम में मेजेंट्रिक सिस्ट, वी आर एक्सपेक्टिंग मेजेंट्रिक सिस्ट. काइलोलिम्फेटिक, एंटेरोजिनस. स्मॉल बाउल ऑब्स्ट्रक्शन इज वेरी इंपॉर्टेंट चैप्टर, मैं आपको बता देता हूँ. इसमें वी कैन एक्सपेक्ट इमेज बेस्ड क्वेश्चन ऑफ क्लॉस साइन इनटू ससेप्शन. क्लॉस साइन, क्वाइल स्प्रिंग साइन. सो गाइस, क्लॉस साइन, क्वाइल स्प्रिंग साइन इनटू ससेप्शन का. दूसरा कॉफी बीन या किडनी बीन, एंड यू नो कॉफी बीन इन सिग्मॉइड वॉलुलस, किडनी बीन्स इन सीकल वॉलुलस. या दे माइट गिव यू वॉल्वुली कॉन्वेंटिस, मीन्स एक्सरे शोइंग सर्कमफेरेंशियल रिंग लाइक पैटर्न. स्मॉल बाउल ऑब्स्ट्रक्शन कौन सा? डिस्टल. स्मॉल इंटेस्टीन से मेकल्स डाइवर्टिकुलम का क्वेश्चन आ सकता है. 3 ट्यूमर में आपको बता देता हूँ. 3 ट्यूमर्स वी आर एक्सपेक्टिंग. फियोक्रोमोसाइटोमा, कार्सिनोइड ट्यूमर, जिस्ट. So pheochromocytoma, carcinoid tumor, just these questions are asked. मैं थोड़ा सा ट्रॉमा से डायरेक्टली बता देता हूँ आपसे क्वेश्चन. क्या क्या क्वेश्चन आ सकता है ट्रॉमा से? सी, EDH, SDH. बाइकॉन्वेक्स हाइपरडेंस लीजन. सो बाइकॉन्वेक्स हाइपरडेंस लीजन, कॉन्केवो कॉन्वेक्स हाइपरडेंस लीजन, NCCT आ सकता है. यस, प्राइमरी सर्वे में एयरवे मेंटेनेंस आ सकता है. GCS we are expecting GCS. Yes, after that diffuse axonal injuries we are expecting. Pulmonary embolism या फ्रैक्चर की वजह से, लॉन्ग बोन फ्रैक्चर की वजह से, व्हाट, फैट एम्बोलिज्म. सो पल्मोनरी एम्बोलिज्म, फैट एम्बोलिज्म, दीज क्वेश्चंस. ठीक है. इसके बाद लार्ज इंटेस्टाइन से वी कैन हैव कोलोरेक्टल कैंसर, FAP, प्यूर जेगर्स, एक जो सबसे इंपॉर्टेंट है कोलोरेक्टल पॉलीपोसिस में, दैट इज प्यूर जेगर्स. राइट. रेक्टम में वी कैन हैव सम क्वेश्चन रिलेटेड टू बिनाइन डिसऑर्डर्स लाइक फिशर इन एनो, फिस्टुला इन एनो, हेमरॉइड्स. मोस्ट इंपॉर्टेंट, दे आर आस्किंग रेक्टल प्रोलैप्स का नाम, विच वन इज एब्डोमिनल, विच वन इज पेरिनियल. अपेंडिसाइटिस में हमने डिस्कस किया एल्वा-रैडो स्कोर, वीडियो बेस्ड क्वेश्चन में, मैकबर्नीज पॉइंट इमेज बेस्ड क्वेश्चन में, दे कैन आस्क द इमेज बेस्ड क्वेश्चन ऑफ इंसिजन्स. मैकबर्नीज, रदरफोर्ड, मॉरिसन, लैंज, कौन सा मसल कटिंग है, कौन सा मसल स्प्लिटिंग है. हर्निया से क्वेश्चन आ सकता है, स्पेशली हर्निया से दे कैन आस्क लैप्रोस्कोपिक हर्निया रिपेयर ट्रायंगल्स, ट्रायंगल ऑफ डूम, ट्रायंगल ऑफ पेन. मोस्ट कॉमनली इंजर्ड nerve during laparoscopic hernia repair, that is lateral cutaneous nerve of thigh. During open hernia repair, ilioinguinal nerve. क्रिस्टल का इमेज बेस्ड क्वेश्चन आ सकता है स्टोन्स में. कौन कौन से क्रिस्टल? कैल्शियम ऑक्सलेट डाइहाइड्रेट, आपको पता है, दैट इज इन्वेलप शेप ऑफ बाइपिरामिडल. मोनोहाइड्रेट, दैट इज डम्बेल शेप्ड और आर ग्लास. कॉफिन लिड स्ट्रुवाइट में, और सिस्टीन में हेक्सागोनल. Stone related tuberculosis is very important. So tuberculosis, small intestine में they can ask you pulled up cecum, Sterling sign, sting sign of Cantor, ये क्वेश्चन आ सकता है. और tuberculosis of kidney से पुट्टी किडनी, कैल्सिफाइड किडनी, ये सारे क्वेश्चन आ सकते हैं. गोल्फ होल यूरेटर, थिम्बल ब्लैडर. राइट. फ्रॉम ब्लैडर वी कैन एक्सपेक्ट अ क्वेश्चन रिलेटेड टू ब्लैडर रप्चर. यूरेथ्रा से फाइमोसिस, पैराफाइमोसिस, पोस्टीरियर यूरेथ्रल वाल्व, जिसमें जो आपको साइन पता है, की होल साइन. और देयर माइट बी वन क्वेश्चन रिलेटेड टू यूरेथ्रल इंजरी. टेस्टिस से NBE पीपल आर इमोशनली अटैच टू टेस्टिकुलर टॉर्शन. तो टेस्टिकुलर टॉर्शन से उनका काफ़ी अटैचमेंट है. दूसरा, उनका सेमिनोमा से काफ़ी अटैचमेंट है. सो दे गिव अ हिस्टोपैथोलॉजिकल स्लाइड ऑफ सेमिनोमा. ब्रेस्ट में सिस्टोसार्कोमा फिलोर्स का इंटीग्रेटेड क्वेश्चन देते हैं, दे गिव अ हिस्टोपैथोलॉजिकल स्लाइड. ठीक है. In arteriovenous disorders we can get a question related to aneurysm and CABG. Venous disorder में आपको क्वेश्चन मैं बता देता हूँ, we can expect question related to CEAP classification. So guys, CEAP classification, अल्सर पूछा जा सकता है, टाइप्स ऑफ अल्सर. यस. लिम्फेडीमा पूछा जा सकता है, दो नॉट वेरी कॉमन. मेडियस्टैनल मासेस दे आस्क यू, एंटीरियर, मिडिल एंड पोस्टीरियर मेडियस्टैनल मासेस. मैं आपको बता दूं, CA लंग से रिलेटेड एक क्वेश्चन होगा, कार्सिनोमा लंग से रिलेटेड क्वेश्चन होगा, आप देख लीजिएगा. CA लंग और एस्बेस्टॉस. और हम लोग रिकॉल में भी मिलेंगे. एंड वॉट एवर आई एम टेलिंग यू टुडे, यू जस्ट मैच. राइट. दिस इज ऑन द बेसिस ऑफ लास्ट 5 years ऑफ ट्रेंडिंग टॉपिक्स. एस्बेस्टोसिस. दूसरा, इन पैनक्रेटाइटिस देयर आर सर्टेन स्कोर्स क्या क्या होना चाहिए? क्यू सोफा, बिशप स्कोर एंड SIRS. रिमेंबर, क्यू सोफा, बिशप, SIRS. इसके अलावा मेल्ड पेल्ड CTP, मेल्ड स्कोर, पेल्ड स्कोर, CTP, ये आप देख लीजिएगा. राइट. सेलिवरी ग्लैंड ट्यूमर्स में दे माइट आस्क यू प्लियोमॉर्फिक एडिनोमा, वर्दिन्स ट्यूमर, ज़्यादा चांस है. फ्रेज सिंड्रोम काफ़ी पूछा जाता है. फ्रेज. अनदर क्वेश्चन जो आजकल काफ़ी पूछा जा रहा है एनाटमी में, आई एम टेलिंग यू, दे आर आस्किंग सब मैंडिबुलर ग्लैंड एनाटमी, सब मैंडिबुलर ग्लैंड एनाटमी, नर्व्स रिलेशन, एंड ड्यूरिंग सब मैंडिबुलर ग्लैंड सर्जरी, स्टोन रिमूवल, व्हाट इज द नर्व इंजर्ड, लिंगुअल फॉलोड बाय हाइपोग्लॉसल. नेक में नेक डिसेक्शन पूछ सकते हैं. पीडियाट्रिक्स में सिस्टिक हाइग्रोमा, कीमोडेक्टोमा, कैरोटिड बॉडी ट्यूमर आ सकता है. बर्न्स का एक क्वेश्चन होगा, in which you have to suppose to in which you have to make the diagnosis of burns. हो सकता है किसी बच्चे में ब्लिस्टर्स हो और आपको पूछेगा ये कौन सा डिग्री है, that's superficial partial thickness burn, second degree. They might ask you the resuscitation formula. Clear? Skin grafting can be asked. Okay, so burn and plastic. After then, head and neck, 2 tumors are important. One is meningioma and glioblastoma multiforme. So meningioma, there is dural tail sign. Yes, सब कुछ आएगा, इसमें से चूज कर लीजिए. ड्यूरल टेल साइन एंड ग्लायोब्लास्टोमा मल्टीफॉर्म, व्हाट, बटरफ्लाई ट्यूमर. सो दिस वाज हेड एंड नेक. ओरल कैविटी, they might ask you some question, but usually क्लेफ्ट लिप क्लेफ्ट पैलेट में, क्लेफ्ट लिप में मैं बता रहा हूँ 6 months, क्लेफ्ट पैलेट में दे आस्क यू एट व्हाट टाइम रिपेयर इज डन. Clear guys? So these are the questions. Oncology में soft tissue sarcoma, most important tumor lysis syndrome. और एक और question, पैनकोस ट्यूमर आ सकता है, पैनकोस ट्यूमर. सेकेंड, सुपीरियर वीना केवा सिंड्रोम, ऑब्स्ट्रक्शन ऑफ सुपीरियर वीना केवा बिकॉज ऑफ कार्सिनोमा लंग. तो ट्यूमर लाइसिस सिंड्रोम, यस सुपीरियर वीना केवा सिंड्रोम. एक क्वेश्चन जो अब मैं बता रहा हूं आपको 100% आने के चांस है, रीफीडिंग, बिकॉज दिस टॉपिक इज बीइंग आस्क्ड कंटिन्यूअसली in INI-CET NEET PG. Refeeding syndrome, what is the main problem in refeeding? Refeeding, yes, hypophosphatemia. So these are the questions. Instrument में various needle we can expect. Bariatric surgery में RYGB, RU-NY gastric bypass आ सकता है, yes, biliopancreatic diversion और duodenal switch. Clear? So guys, these are the questions we are expecting. ये ज़्यादा important है. Right? By the way, this is just the end and you guys are having 3-4 days. So just quickly revise the things. This point of time, don't panic. You have studied nicely. You put your effective, you put maximum hours into the preparation. So this is the time when you just revise the stuff. आपके पास जो भी 20th notebook है, revise कर लीजिए. Video based question का कोई भी load लेने का नहीं है. बिल्कुल भी नहीं, लोड मत लीजिए. 1-2 क्वेश्चन आपको नहीं आएंगे, बाकी ज्यादातर आपको आ जाएंगे. क्लियर? राइट? सो एट दिस पॉइंट ऑफ टाइम डोंट टेक एनी काइंड ऑफ स्ट्रेस. दूसरा, एमसीक्यू सॉल्व करते समय 2-3 प्रिंसिपल फॉलो करना है गाइस. हम इसको बोलते हैं लास्ट प्रिंसिपल. एंड व्हाट इज लास्ट प्रिंसिपल? द मोस्ट इंपॉर्टेंट पार्ट ऑफ एमसीक्यू, लास्ट स्टेटमेंट. मोस्ट इंपॉर्टेंट वर्ड ऑफ एमसीक्यू, लास्ट वर्ड. एंड मोस्ट इंपॉर्टेंट ऑप्शन ऑफ एमसीक्यू, लास्ट ऑप्शन. तो आप क्वेश्चन पढ़ेंगे, लास्ट स्टेटमेंट सबसे इंपॉर्टेंट है, उसका लास्ट वर्ड देखिए, ऑल एक्सेप्ट तो नहीं दिया है, और लास्ट ऑप्शन चेक, ऑल ऑफ द अबव तो नहीं दिया है. राइट? सो क्वेश्चंस आर 180 ओनली. यू हैव सफिशिएंट टाइम, रीड इट प्रॉपर्ली. वॉट एवर योर गट फीलिंग इज गोइंग टू से, मार्क इट. और जो पहली बार आपकी गट फीलिंग आती है ज़्यादातर वो सही होती है. जब हम आंसर चेंज करते हैं, मैं आपको बता दूं, ज़्यादातर केस में व्हेन वी आर गोइंग टू चेंज द आंसर, इन दैट केस हो सकता है गलती ज़्यादा हो जाए. इजी. तीसरा इंपॉर्टेंट पॉइंट, अगर मान लीजिए 8-10 क्वेश्चन आपको नहीं आते एंड इन टॉपिक इज अननोन, यू डोंट नो द आंसर, तो अगर आपको कोई क्वेश्चन नहीं आता, मान लीजिए 4-5 क्वेश्चन नहीं आते, 4-5 क्वेश्चन यू डोंट नो, विच ऑप्शन यू मार्क? ईदर मार्क सी और मार्क बी. सबका या तो सी मार दीजिए या सबका बी मार दीजिए. अगर आता है, मार्क द करेक्ट आंसर. नहीं आता, मार्क द सेम ऑप्शन फॉर ऑल ऑफ देम. और आपको लगता है कि नहीं यार मेरे को बिल्कुल आइडिया नहीं, मेरे को छोड़ना है तो छोड़ सकते. अगर अटेम्प्ट लेना है, यू कैन मार्क. क्लियर? ATLS पार्कलैंड में मैं बता दूं, ये क्वेश्चन अभी FMG में आया था. दे आस्क्ड वन क्वेश्चन ऑफ फॉर्मूला पार्कलैंड. दे मेंशन्ड दैट अकॉर्डिंग टू ATLS मॉडिफिकेशन. तो अगर वो आएगा, दे विल मेंशन ATLS मॉडिफिकेशन. ओके गाइस, सो आवर बेस्ट विशेस आर विथ यू. वी होप दैट यू आर गोइंग टू क्रैक दिस एग्जाम विथ फ्लाइंग कलर्स. We are with you and we'll meet on 30th. Okay guys, so study hard, revise, relax also and take care. All the best. Thank you very much.